So with that, I'm going to shift gears and I'm going to introduce our guest speaker for, I think it's our fourth COVID Consortium Colloquium, Wednesday morning colloquium. And it is really my great pleasure to introduce Dr. Jeff Shaman. Dr. Shaman is an epidemiologist at Columbia University, where he's the director of the Climate and Health Program. And I am not exaggerating when I say that Dr. Shaman almost single-handedly launched the field of epidemic forecasting with his pioneering work on elucidating the relationship between flu transmission and humidity, and really importantly, his revolutionary flu forecasting models that were the first to combine traditional SEIR type models with Bayesian data assimilation methods from weather forecasting, and also to resourcefully combine different kinds of data, health data, environmental data, even social media data to drive those predictions. Since January, Dr. Shaman and his team at Columbia have been hard at work on the front line, projecting COVID, modeling interventions to support situational awareness and public health responses by New York and by the country. So Jeff, we are really grateful to you for taking time to speak with us today, and especially for your game-changing and life-saving contributions to pandemic modeling. So please, the floor is yours.
Thank you, Lauren. That's very kind. So I was told that I could speak just extemporaneously, not with slides and whatnot, and I thought I would do that. Hi, everybody. Nice to meet this group that's formed, and I think this is wonderful that you're doing it. I wanted to throw out, just before I dive into some COVID, something that came up yesterday that follows on this whole science STEM pause that you were just talking about, and some of the disparities. I think that there are many studies going out right now that are focusing on how COVID is bringing into relief the enormous disparities in healthcare along racial and ethnic lines, as well as socioeconomic lines. I was at a talk yesterday, and Wafa El-Sadr, who runs ICAP, which is this thing Lauren and I were to speak at early this morning, but had some technical issues, had put up this slide, and it was remarkable to see. It was all these studies that, and it just says racial and ethnic disparities is not a new issue. White medical students and residents often endorse false beliefs about biological differences, and rate the Black versus white patient's pain as lower and made less accurate treatment recommendations. That's a study in PNAS. In emergency departments, non-Hispanic Blacks are 1/2 to 2/3 less likely to receive opioids for pain than non-Hispanic whites. That's a study from PLOS One. Studies have consistently shown that Black African Americans are less likely to get access to advanced treatments, chemotherapy, transplant surgery, cardiovascular interventions. Those are studies in several journals, including the Journal of Surgery. And Black patients that exhibited COVID-19 symptoms were 6 times less likely to receive testing or treatment. And that is obviously a very recent paper. So a lot of systemic racism is taking place that doesn't just cut across the lines as a result of economic opportunity and employment and housing justice issues and where people live and access to treatment. It's also how they're being treated is actually very subtly, one might say, or maybe not so subtly, being discounted. I'd also say, you know Michaela Martinez, Lauren? Do you know who she is?
I've never met her, but I've been on many CDC Monday Zooms with her now, and she's very,
okay.
Yeah.
Well, she had a very, she was at a protest last week, and she wrote something up for City's Council about it, and where she was in a group. She's Hispanic and Native American. And she was marching in the Bronx in a community of color about the George Floyd and other police incidents, and she was kettled. And then the crowd was before curfew, and then they were beaten, and then they were zip tied too tight, and then they were taken to a precinct where the commanding officer there walked around saying he had COVID and coughing deliberately in people's faces. It was really remarkable what's going on. So just so you know, that was a first-person account she sent around along with the City Council. So I'm curious to see where that goes and where she may output that as well elsewhere. All right, on that happy note, I'm going to pivot. I'm going to just say that thinking about COVID, where I came from it was work we had done looking at respiratory viruses broadly in New York City. We had this project where we had gotten money from the DoD to do something called the Virome of Manhattan. It had a number of aims, but one of them was to try to document the real prevalence of respiratory viral infections in the broader community and try to understand how they get around and how much virus there is out there. And I'm telling you about this not because necessarily it is a incredibly unique study, but because it really informed our thinking and how we approached COVID-19. So in this study, we had a couple of arms. One of them was we went to a major tourist attraction in New York City. I'm not allowed to tell you what it is since it's a major tourist attraction, but it's a big one. And we solicited volunteers there who were visitors to that tourist attraction. And we would ask them, after consenting them, to give us medical history. And we would give them a common cold questionnaire where they would tell us on a scale, none, mild, moderate, or severe, a Likert scale, symptoms with respect to 9 symptoms they had. Things like chills, sore throat, cough, runny nose, sneezing. They would rate all those for us for the last 48 hours. And then we would swab these individuals, take a nasopharyngeal swab, take it back to the lab, and we test it for 18 different viruses. And what we were curious about there was, well, just how much virus is there in this ambulatory adult population? Because the tourist site didn't want us swabbing children. So what we saw was something kind of remarkable, and that was that depending on the month, between 5 and 11% of individuals were shedding a common respiratory virus. And February was the high month, and 1 in 9 individuals was shedding a virus. These are people who are walking around doing things. They're from all over the world or all over the country and even the city as well. And it's quite remarkable to see just how much contagion is being dispelled into the community and how much that might be providing opportunities for it to get around, get from person to person, or maybe more importantly, from household to household, where once it's in a household, it's going to have greater chance of moving person to person there. Another arm that we had was a cohort arm. And in this cohort arm, we asked people upon enrollment in it to keep a daily log of those cold and flu symptoms. Same deal, 9 of them rated on this Likert scale that they would enter over their phone into an electronic database. So we get this daily time series record of symptoms. We also would get ask them to tell us if, because of their respiratory symptoms, if they had stayed home from work or school, if they had taken medicine because of those symptoms, or if they had gone to see a doctor. And then once a week, regardless of how they felt, we would swab them. So we put all this together and we have a time series of symptoms, a time series of response to those symptoms, and a time series of actual infection. And again, for those swabs, we would test them for 18 different viruses. So a couple of things that we saw. Firstly, there's a lot of infection, a lot more infection than there is what you would consider ILI, anybody reporting a fever and a cough or sore throat. Secondly, the definition of asymptomatic is really squirrely. And if you go into the literature, you see that there is no real definition of asymptomatic. There's no settled on one, which seems weird because it should just be without symptoms. That's what the word means, right? But the truth is, we saw that there were individuals in our cohort who reported symptoms every single day. Maybe they have fibromyalgia or chronic rhinitis, or they're just a hypochondriac, but their set point was one where they were constantly reporting symptoms. And then we also had individuals who never reported symptoms, and it didn't matter what virus they got, they never budged off of, no, I'm fine. So looking across that, we immediately struck that this whole asymptomatic definition is really challenging. So what happens is we try lots of them. We'll try things where we say, well, you can have a couple things that you're feeling mild for, which is the first thing above none. And you try lots and lots of them. And no matter what definition you throw at them, unless you throw absolutely nothing, saying you can't have any symptoms, you got to be nones across all 9 symptoms. And we're looking around infection events. So we look at an infection and we'll look from 3 days prior to 7 days afterwards. So an 11-day window around that positive swab. How were they feeling? What is the cumulative symptoms? So to have no symptoms over those 11 days, you have to have nothing reported. But if we raise it there, the majority of infections are asymptomatic. But what is more revealing is not to look at that asymptomatic dividing line. That was what really pushed us to think asymptomatic isn't the important thing. What the important thing to our mind was did they stay home? And did they go see a doctor? And when we look at rates of staying home, those were less than half the time. Now, mind you, that's just staying home one day out of 11 maybe, right? That's not saying that they're staying home the entire time they're shedding.
Sorry, this is staying home while you're getting positive swabs from them? Is that
right? In the window around the time that they're positive, during what we then called the infection episode, which is that they might have had multiple weeks in a row with the same positive virus, right? What was even more revealing was that when we look at the rates of seeking medical attention, they're very, very low. And for a viral infection episode, it ranged from 4% of the time to 22% of the time, depending on the pathogen. So this is the conditional probability that you seek medical attention, given that you're infected with flu, which was 22%, or human metapneumovirus, which was 20%, or endemic coronaviruses, which was 4%. And the majority of infections, people were not seeking medical attention, which means, given the way that we do surveillance for respiratory viruses, these individuals are undocumented, right? So we have a passive surveillance system for monitoring respiratory viruses. We wait for people to come seek clinical attention. If they happen to go to a sentinel lab, then they're going to be documented syndromically as ILI, and they may be tested, right? So given this passive state, we are missing a lot of the symptoms, a lot of the infections that are out there, the majority of them, really from 80 to 95% of infections, depending on the virus, are missed. There's no opportunity to actually document them. And it also showed us, by looking at the rates that people stayed home, that people help get these viruses around. The thing that may very well facilitate their ability to move around is the fact that when people get a little bit of a sore throat or a little runny nose, in the wintertime, they do what you and I do, which is nothing. We go to work, you know, we go shopping, we go to a restaurant, you go to a show, you get on public transportation. Do you have public transportation in Austin? I think you do.
not much?
Not much. All right, fair enough. Car culture. But, you know, and even more importantly, perhaps, you get on an airplane, you have a business trip, you're not going to let that stop you. And even if you felt actually pretty bad, if it was something that was important to you, you might just take some cold or flu medicine or pop some ibuprofen and get on the plane anyhow. So what does that mean? It means that these viruses are getting out and about in the community, and they're able to move from household to household and individual to individual because there is so much undocumented infection around and movement that allows them to just be spread broadly in the community. It allows them to be geographically translocated. And it is this that really supports and sustains these viruses and their movements in our community. And that without having this silent spread of people who are asymptomatic or mildly symptomatic, whatever you want to call it, but who are undocumented, because they don't feel bad enough to go see a doctor, and they go out and they do their business for much of the time that they're sick, that helps get the virus around. So when we saw COVID-19 in January, and that's when we really started to see it in China, and we saw how rapidly it was spreading within China, which is in contrast to things like H7N9 or H5N6 or H5N8. And we saw that it was getting on airplanes and moving to Thailand and Japan and South Korea and the US. It immediately struck us that this thing has to be functioning like a common respiratory virus. It has to be having a lot of undocumented infections. Now, we can quibble about how much it's asymptomatic or mildly symptomatic, or people who are just toughing it out at home because they hate doctors. But what you have is a lot of opportunity for the virus to get around where people aren't aware that they themselves are infected with it and are giving it to other people. So what we did is, in that first look at it, we said, well, let's see if we can estimate how much of this is going on. And we developed a model, a metapopulation model for China, where we set up 375 different cities linked together dynamically. And we combined that with mobility data from cell phone records and case counts for a 14-day window from January 10th to January 23rd. And the aim there was to look at this period just prior to the crackdown, which was January 23rd, where the virus is moving around in its natural state, as it were, and see if we could estimate both a bunch of things: the latent period, the infectious period, the transmissibility of the virus amongst documented infections, but what fraction of infections were documented versus undocumented, and how contagious undocumented infections were per person relative to documented infections. We were able to show that the system was identifiable, and then when we applied it to the data, we've estimated for China, for that short period of time, 1 in 7 individuals who was infected was actually being confirmed. And we also showed that those undocumented infections were about half as contagious. So there was some relation perhaps between severity of illness and contagiousness overall, but there was still contagiousness in the undocumented. And we were able to show through counterfactual simulations that without those undocumented infections, 80% of the cases would have disappeared. Because there's so many more of them, because 86% of people who are infected are undocumented, even though they're half as contagious per person, because there are more of them, they're responsible for the lion's share of transmission of the virus. They're setting up these silent chains of transmission that is allowing this virus to get around within communities, to move geographically as well. And lastly, I'll just stop here, is that we also were able to see that there was pre-symptomatic shedding amongst those who were documented cases. We estimated it at about 2.5 days. So what we saw immediately was something that gave us real pause and concern, which is that we had a virus that had 3 critical characteristics that make it very dangerous. Firstly, it's a novel respiratory pathogen to which most of the world population is susceptible. Secondly, the majority of infections are silent. They're undocumented. People aren't aware that they're contagious, and it easily gets around and moves from community to community and within communities. And third, it has a fat tail. There still are a substantive number of people who have critical complications and are at risk of death due to the infection. You put all that together and you have the worst emergent virus situation we've seen since 1918. So I'll stop there.
Thank you so much, Jeff, for all the interesting perspectives and sharing your work. And that last thing, which kind of puts it in a nutshell, why this is the perfect storm.
Yeah.
So I'm going to start with a couple questions and then I'll open it up. So actually, I want to start just a comment. So and then a question. So a few years ago, I think in 2016, we published this study. Roz Ego is the first author, looking at trying to estimate the transmission dynamics of what you're calling undocumented common colds through the lens of asthma exacerbation data, right? Mm-hmm. With the idea being that these are sort of the canaries in the coal mine, the kids and the adults who have asthma, when they get these common colds, they're the ones who actually get documented because they have more severe outcomes. And when you look at the hospitalization data, you really see this sort of these epidemic curves, these seasonal curves that reflect probably multiple viruses circulating on a fairly regular basis. And so I think what you're saying is sort of very consistent with what we saw through that kind of lens on it. But the question about it is, and I think as I was trying to do the calculations in my head, that it all kind of checks out. But our estimates that were consistent with prior studies were that on an annual basis, adults have around 2, maybe up to 4 common colds per year and infections per year, and kids have upwards of 7, maybe 3 to 8. Is that sort of consistent with what you were finding in your studies?
We averaged across, I remember the number off the top of my head for the average of children and adults. Okay. So I don't know how it's going to jive onto that, but we got about 4 infection events per year. Okay. But real variance on that. Yeah. Where, we had some small children. I mean, holy moly. We had, like 3-year-olds who were just 12, 14 infections in a year. Wow. It was unreal. Wow. And so the distribution is there, but that does sound roughly consistent. Whereas, the number of ILI episodes was around 1, so, yeah. Right.
And did you were you able to estimate at all the duration of shedding or duration of infection for a typical cold infection?
Well, yeah, I mean, we can look at that and we could certainly see, for instance, that like influenza was more temporally acute, whereas rhinovirus and coronaviruses tended to produce shedding for longer periods of time. The milder ones, people did not seem to clear the same way they did with influenza and human metapneumovirus, where basically it was 1 week and then it wasn't there anymore.
I see.
Yeah.
Interesting. Then my last question, and then I'll open it to others, is, I think your work on asymptomatic transmission is really important and fascinating. And the question on everybody's mind right now is what's going to happen when kids go to school, and how contagious are they going to be, particularly. So, the sort of working assumptions now are that kids are more likely to be mildly symptomatic or asymptomatic, however you want to define it. It may be that mildly symptomatic, asymptomatic infections are less contagious. What's your guess? How do you think that might play out?
Well, I think there's sort of, the literature that I've seen is sort of confusing. I've seen studies, I think one from Germany, where they looked at the rate of shedding across different age groups. Did you see this one? And I think they found that the shedding rates were similar, even though the symptom profiles weren't. So that suggesting that they're similarly contagious. Another found that, or think of one from China, that children were 1/3 as likely to pick up the virus, but because they have roughly 3 times more contacts, they're just as likely to get it and then pass it on. I don't think children are all a dead end for this. I don't think there's any evidence for that. So I would say we can put that aside. I think they participate in the transmission cycle of COVID-19. I think that reopening schools, and when somebody quoted the numbers yesterday to me, and when you think of the number of school children that are going to be going back, and the number of teachers, it just sounds like a disaster in the making to me. It's something that I actually think is a very bad idea. Now, there are enormous problems not doing it. There are enormous educational gaps, and again, coming across socioeconomic and racial lines, the ability to have access to schooling remotely is very different as you go from community to community, and as you become more poor and impoverished, and that tends to align with certain ethnic and racial groups, you're going to have less and less access to the teaching that might be done virtually. So there are enormous problems of people being left behind that really can't be undersold. But I see this as a real problem, putting kids and teachers back together again. It seems to me a perfect way to allow the virus to move from household to household.